Hey everybody, so today we're going to be going over Annaville Fire Department's protocols. If you are an employee of Annaville Fire Department, this can be a great tool to go over the protocols if you're having trouble reading it on your own. If you're an aspiring paramedic or EMT, or you're just curious, this can also be really good information to kind of see our mindset of what we're going to do on the field. These are great protocols. We use them as guidelines and we can use them to really help ourselves out, but don't be afraid to call medical control either. If you have any questions though, if you want to know or look for a specific topic, look at the description. I'm going to timestamp everything if YouTube allows me to. I'm hoping this is going to be a quick video. We're going to see though, this might take a lot longer than I'm expecting, but here we can kind of see the table of contents. If you want to pause this and take a look at a certain section, here you go. We have some more right here. And we're going to be going over all these topics. We are going to skip the medication list, but that's just because that can be saved for like another time. I don't want to make it longer than it has to be. And we have section 1, the introduction. So this introduces patient care protocols and standing orders. These are all very important. I will be kind of skipping over this, but make sure you maintain these protocols. These are extremely important. These are things that you should know. But let's move over to the definitions. So for vital signs for an adult patient, they're considered to be hypertensive if their systolic blood pressure is greater than 220 units and or a diastolic blood pressure at 110 or greater units. If they're hypotensive, it's considered to be hypotensive if a patient has a blood pressure less than 100 units. For tachycardia, it's a heart rate greater than 100 beats per minute. For bradycardia, it's less than 60 beats per minute. For tachypnea patients, it's a respiratory rate greater than 24 breaths per minute. They're considered hemodynamically stable if a patient does not have hypotension, tachycardia, or evidence of impaired generalized perfusion, such as a delayed capillary refill. For hemodynamic instability, it's a patient who has hypotension, tachycardia, or evidence of impaired generalized perfusion, such as a delayed capillary refill, etc. For some age definitions that are really important, it's for a neonate or newborn being less than 28 days old. For an infant, it is less than or equal to 28 days old or less than 1 year old. A child is someone who is greater than or equal to 1 year old to less than 8 years old. And a pediatric patient is less than or equal to 16 years old or a body weight less than 40 kilograms. For an adult, to anyone that's greater than 16 years old or if they weigh greater than or equal to 40 kilograms. This is really important for medications, for your levels of care, for a basic life support individual or for BLS and EMT-B. The skills that you're allowed to do are the following, and this is just for Annaville Fire Department, by the way. Your protocols may be different. Please look at your own protocols. Spinal motion restriction, bandaging, splinting, dressings, cardiopulmonary resuscitation for adults, children, or infants, so CPR, OPAs and NPAs, oral suctioning, oxygen administration, including a BVM, an AED, blood glucose assessment, pulse oximetry, emergency childbirth, traction splints, albuterol nebulizers, intramuscular or IM 1 to 1000 epinephrine, oral glucose, iGel devices, which are Annaville Fire Department only for a BLS provider, and you have to get checked off first, and peripheral intravenous access, which is also Annaville Fire Department only. It's a BLS skill. However, you need to get checked off. For an AEMT or an advanced emergency medical technician, you can do all the skills above, but you can also administer acetaminophen, which is Tylenol, aspirin, calcium gluconate gel, 2.5% topical, D10, diphenhydramine, which is also known as Benadryl, naloxone or Narcan, methylprednisone or Solumedrol, or ondansetron or Zofran. Regarding EMT-Ps or emergency medical technician paramedics, you can do every skill above, but you can also go ahead and do an oral tracheal intubation. You can do ETCO2 monitoring. All the medication authorized in this protocol manual, that's around page 100, 105. You can do pacing or transthoracic cardiac pacing. You can do pleural decompression. You can do external jugular venous cannulation. You can do intraosseous access, a 4-lead EKG interpretation, manual defib, and synchronized cardioversion. That's a really big one. You can do 12-lead cardiac monitoring and interpreting. You can administer CPAP. You can administer medication via an intranasal mucosal atomizer device. And you can perform peripheral IV access, which is an approved skill that for EMT-Bs as well. So Those are generally everything you can do. We don't have access to things such as surgical crikes. We also don't have access to its RSI protocols, but I'm okay with it, honestly. And these are some of the minimums for Texas DSHS. It defines a minimum needed for an ALS ambulance for BLS equipment. We also have the same equipment for a MICU ambulance. For receiving hospitals and diversions, it talks about how you need to appropriately transport your patients to either the closest hospital, unless you have like a child or something like that, or if it's a certain type of trauma. Watch out for hospital diversions. Here it talks about transfers, bypassing a hospital, regional EMS systems, but all that's fine. Now, a really big section here is the trauma criteria section. For patients who meet level 1 trauma code activation and level 2 trauma alert activation criteria, will be transported either directly to this one hospital that's in regards to, it's kind of like our trauma hospital, or Driscoll's Children's Hospital for non-penetrating pediatric traumas. If not, you are going to go to Chris's Spawn Shoreline. It's just for our region, though. Just going to depend on your region. And for the level 1 trauma code activation criteria, it's for ones that are traumatic arrest, sufficient facial trauma that can compromise the airway, signs of hemodynamic instability, the respiratory rate, if it's less than 10 or greater than 29, of course it's age appropriate because a newborn or a toddler is going to have different vital signs than an adult, for instance, a systolic blood pressure that's less than 90 millimeters per mercury, a head injury, and a GCS score that's less than or equal to 13, intubated trauma patients, penetrating injuries to the head, neck, torso, or extremities with vascular insults, which means pulse deficits, any trauma patient who presents with acute limb paralysis, 2 or more proximal long bone fractures, amputations proximal to the wrist or ankle, burns greater than 15% for second and third degree burns, or with respiratory distress and inhalation injuries, transfer of patients receiving blood to maintain their vital signs, pelvic instability with hypotension. For a level 2 trauma alert, this is someone with pelvic instability, flail chest, an open or depressed skull fracture, ejection from the vehicle, falls greater than 20 feet for adults and 10 feet for children, pregnant trauma patients that are greater than 20 weeks gestation with injuries or pain. For patient assessments and patient transports, we like to utilize sample, which is signs and symptoms, allergies, medications, past medical history or past surgeries, last oral intake or last menstrual period, and events of the accident. We also like to utilize OPQRST, which is onset of pain, the provocation of pain, the quality of it, does it radiate anywhere, the severity on a scale of 1 to 10, and the time or the duration of the pain. We also like to gather, whenever we're doing our primary assessment, AFPU, which checks for a patient's alert response, if they're verbally responsive, if they respond to pain, or if they're unresponsive, and it just kind of goes down. Here's some other things, blah, 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 it's fine. We talk about obtaining a sample, our standard of care, patient benefits from early medical interventions. We talk about going code 1. For these type of calls, it's whenever a patient is in a non-urgent situation, and they're not going to decompensate, or at least there's a very small chance. Whenever we're going code 1, we're not going to go lights and sirens. We're just going to go nice and calm to the hospital. Code 3 patients, we're going to have lights and sirens. This is for life-threatening emergencies where we think our patient could potentially die or lose a limb or something along those lines. We're going to have lights and sirens going on the whole way to the hospital. For these patients, if we're going code 3, for Annaville at least, we must have a paramedic in the back. We want to check vital signs at a minimum every 5 minutes until we go to the hospital if we're going code 3. However, if we're going code 1, the minimum should be about 15 minutes whenever we reassess vital signs. Here it talks about interventions going to the hospital. If it's a code 3 call, one of the big things is we want to establish an IV while we're heading to the hospital. We don't want to do that on scene. Although personally, I kind of still like to gather it on scene. It's just how our protocols go though. Right here, we're going to go into the medical situation. So here is the interesting part where we start talking about different topics, right? So first we have abdominal pain. This is a very big deal. So it's medical, it's non-traumatic. An abdominal pain may be caused by a wide spectrum of illnesses. It could be potentially life-threatening causes and may require surgery. So we want to have a quick transport if possible. You want to make sure you gather OPQRST, like we talked about earlier. We want to make sure we get our pertinent negatives. So ask a patient if they have nausea, if they vomited, do they have pain anywhere, do they have diarrhea. These are the 3 things I really like to ask. ask about constipation, check if they have a fever, if there's any urinary symptoms. This is a UTI issue, right? Check for bruising, tenderness, guarding, rigidity, and so forth. For BLS, it's pretty straightforward. You just want to check your ABCs, or airway, breathing, circulation, have suction ready in case they're going to vomit, apply oxygen, vital signs, put them in a position of comfort, and do not give them anything by the mouth or keep the patient NPO. That's because they may require surgery, and we don't want to mess that up by giving them something via the mouth like some water or a snack or something, and then it pushes their surgery back further than what they need. Check their blood glucose levels and establish a pulse oximetry or check their oxygen level. For an advanced individual, or for ALS or a paramedic, we want to establish IV access if it's indicated. We want to administer IV fluids if necessary, between 250 to 1,000 mLs or 20 mLs per kilogram for a child IV if the patient is hypotensive. We wanted to monitor EKG rhythm. This is such a big one. For any abdominal call, we need to get a 12 lead on a patient. That's not acceptable to not do that, at least in my department. We need a 12 lead. For patients with active vomiting, administer ondansetron or Zofran. We want to do that at 4 milligrams, 2 milligrams for a child, either IV or IM. We want to rule out abdominal trauma. We want to consider if the patient's pregnant or not. We do want to consider if somebody's having an acute abdominal aneurysm in a patient with severe abdominal pain and their age is greater than 50 years old. We want to watch out for ischemic heart disease, and it can radiate to their abdomen. We want to make sure that they're not receiving routine narcotic analgesia, which can potentially cause constipation. And for these patients, one thing that we're also really concerned about is renal caliculi, or calculi, also known as kidney stones. They can be extremely painful. If an adult patient has suspected kidney stones, then we want to make sure that they're very comfortable. We want to give them something such as morphine sulfate, 2 milligrams to 10 milligrams IV or IM, or fentanyl, 50 to 100 micrograms. We want to watch out for signs of peritonitis, which is decreased bowel sounds, preference to lay still, and rigid abdomens. Usually this indicates a surgical abdomen. We want to watch out for green-colored vomiting in an infant, and that's a very big emergency. We want to watch out to make sure that they're not having any internal bleeding, and we want to watch out for appendicitis. They're also potentially going to appear with right lower quadrant pain. They might have a loss of appetite. The next section is airway obstruction, choking, stridor, or laryngospasm. And we want to see for their history, did they possibly have a choking episode? Were they exposed to a foreign body or an object? Potential food aspiration? Do they have a history of stroke with impaired swallowing, an allergic reaction, prior throat surgeries, and recent upper respiratory infections or a fever? We're looking for things like dyspnea, which is just abnormal breathing, dysphagia, which is difficulty swallowing, dysphagia is difficulty speaking, oropharyngeal swelling, and shortness of breath. So for BLS, we can do a couple different things here. We can maintain airway. We can use a jaw thrust if necessary to open the airway. We can apply oxygen via a non-rebreather mask or BVM if needed. If a partial airway obstruction is suspected and the patient is conscious and is still able to talk, leave the patient in a position of comfort, often sitting and leaning forward, and encourage the patient to cough deeply. When a complete airway obstruction is present, the patient is unconscious or can't talk, check the oral cavity for a foreign body. If the foreign body can be visualized, a finger sweep can be done if it's an adult. If you're unable to ventilate, reposition the airway. If still unable to ventilate, institute 5 back blows if the patient allows, and alternate with 5 subdiaphragmatic abdominal thrust, which is also known as the Heimlich maneuver. Chest thrust can be used instead of abdominal thrust if the patient is obese or in the 3rd trimester of pregnancy, and an infant, deliver 5 back blows followed by 5 chest thrust. Open the airway and repeat the finger sweep. If a foreign body can be visualized, do not attempt a blind finger sweep in either an adult or a child. Blind finger sweeps can potentially push the obstructing fluid further into the airway. Just reattempt to ventilate. If the above is a complete airway obstruction, the steps have been followed without success, the LifeVac airway clearance device, which we just recently got, can be utilized. The LifeVac consists of a face mask that fits over the nose and the mouth attached to a plunger with a one-way valve. Place the properly sized mask over the patient's nose and mouth to create a seal. Push the handle all the way down and pull up with one swift motion to create a suction. I'd highly recommend looking into LifeVac. I don't think it's that expensive, and even if you're a civilian, you can get something like this on Amazon, and it can potentially save a child's life. So it's definitely something you want to consider having on hand. Simple instructions are place, push, and pull. The life back step may be repeated if necessary. Repeat the steps above if necessary, obtain vital signs, get pulse oximetry, and continually reassess patient's level of consciousness, their ABCs. If the patient is unconscious and the patient loses their pulse, start CPR. For ALS, in the unconscious patient, the paramedic should attempt to ventilate and intubate the patient in the standard way. If the intubation is unsuccessful and the obstruction is unrelieved by the outlined methods, use the laryngoscope to visualize the larynx. Attempt removal of an observed foreign body with suction or the Magill forceps. If the airway is clear without any spontaneous respirations, perform an oral tracheal intubation. Monitor an EKG rhythm. Of course, we're probably establishing this pretty late if we're worried about choking. Establish IV access. If they're hypotensive, go ahead and give them saline. Consider albuterol if the patient's wheezing. Consider epinephrine if the patient has severe stridor with no history of coronary artery disease and age less than 50 years old, is not pregnant, and no foreign body suspected. Consider diphenhydramine, which is Benadryl, 25 to 50 milligrams or 0.75 milligrams per kilogram for a child, either IV or IM if the patient is suspected to have an allergic component to their airway obstruction. Frequent reassessment with close monitoring of the airway is important. The above protocol is mainly directed for a suspected foreign body. If no foreign body is suspected and the still conscious patient has evidence of an airway obstruction, such as epiglottitis, a mass, etc., it may be determined to leave the patient supine and to look with the laryngoscope. In these cases, leave the patient in a sitting position. The patient has a tracheostomy with a suspected mucus plug, attempt to suction the patient. If you're unable to clear the secretions easily, instill 5 milliliters of normal saline into the tracheostomy while the patient inhales, and repeat suctioning. If the mucus plug persists, consider removing the inner cannula, if present, to clear the obstruction. In rare cases, it may be necessary to remove the entire tracheostomy, the Shiley tube, and replace it with a cuffed endotracheal tube. Exercise excellent judgment before removing a tracheostomy tube, which has recently been performed within 1 month of surgery, as it may not have a well-healed tract to the trachea, and a replacement tube can be inadvertently placed in the pretracheal tissue plane anterior to the trachea. If the airway obstruction is suspected to be the result of an anaphylactic reaction, refer to the Allergic and Anaphylaxis protocol, which we'll go over in a bit. Cardiac and/or respiratory arrest in infants and children is usually the result of airway obstruction and should be considered as such until proven otherwise. Always consider a foreign body, such as peanuts, hot dogs, marbles, toys, etc., in a pediatric patient with a sudden onset of wheezing, especially if there's no history of upper respiratory issues. For foreign body aspirations, these are the most common causes of sudden respiratory distress or cardiac arrest in a previously healthy child. For epiglottitis, this is a really big one, especially for people taking the NREMT-B. Historically, a life-threatening bacterial infection in a 2 to 6-year-old, which usually starts suddenly, the febrile child will appear toxic, sitting up and leaning forward in a tripod position. They'll have inspiratory stridor and may be drooling. Drooling is the big one. Never try to place the patient supine. Notify the hospital of the possible case so the anesthesiologist can be prepared for a possible fiber optic intubation. In many cases, it may be better to withhold an IV attempt in a suspected pediatric epiglottitis patient. Any agitation may worsen the stridor and cause a complete airway obstruction. It is best not to agitate them for a potential airway compromise. It may be best to have the guardian parent ride in the back of the ambulance with the child to minimize their stress. You definitely should do this. Recently, epiglottitis in children have become very uncommon since the advent of the H. influenza type B vaccine, and nowadays most cases of epiglottitis occur in adults. Epiglottitis is typically less severe in adults given their larger airway size. There's also croup, which is also terrifying, a viral infection of the subglottic tissue in a child between 6 months to 4 years old, which usually has a more gradual onset than epiglottitis. Croup is often worse at night. The child will have an inspiratory stridor, hoarseness, and a barking cough. Some will describe the cough as seal-like. It is treated with humidified oxygen, intramuscular epinephrine, and corticosteroids such as methylprednisolone as needed. The next section is allergic reactions or anaphylaxis. So allergic reactions and anaphylaxis or anaphylactic shock represents the ends of a spectrum of the same problem. Allergic reactions consist of hives, which is also known as urticaria, nausea, mild wheezing, but can progress to anaphylaxis quickly. Anaphylaxis, or anaphylactic shock, is the most severe form of an allergic reaction, consisting of hypotension, stridor, and bronchospasm, and it is a life-threatening condition. Prompt treatment of anaphylaxis is essential. Typically, the shorter the onset from contact to symptoms, the more severe the reaction. You want to watch out for a history of allergies or anaphylaxis in the past, a history of angioedema, which just means facial edema or swelling, new foods, especially nuts, shellfish, new medications, especially antibiotics, new detergents, new cosmetics, soaps, chemical exposure, insect stings or bites, time of the exposure, is it rapidly progressing? For symptoms, you want to watch out for pruritus, which is the itching of the skin, difficulty breathing, wheezing, drooling, swelling of the face, the mouth, a metallic taste in the mouth, hoarseness, chest tightness, lightheadedness, nausea, or vomiting. For physical examination, watch for flushing of the skin, hives, swelling of the face, tongue, or mouth. You may have wheezing, hoarseness, stridor, or hypotension. So, for BSI, you want to watch out for scene safety. If you can, safely and rapidly remove the patient from the source of exposure, such as chemicals, bees, wasps, fire ants, and other insects. Make sure you watch out for ABCs. Apply oxygen via a non-rebreather mask. Assist ventilations with BVM if needed. Obtain vital signs. Administer albuterol, 5 milligrams via nebulizer or 2.5 milligrams if it's a child. Consider epinephrine 1 to 1,000 intramuscularly at 0.3 milligrams or 0.01 milligrams if it's child intramuscularly, if indicated. If a patient is having severe respiratory distress and or hypotension. Epinephrine should be administered with extreme caution to patients greater than 50 years old, as patients with a history of coronary artery disease or pregnant patients can potentially be in a higher risk class. Always weigh the risk and benefits of epinephrine in these high-risk patients. Pulse oximetry, gather their home medications and send them to the hospital with the patient. If an insect sting is suspected, refer to environmental emergencies on page 39. Right now we're on page 23. Apply ice to insect bites to decrease swelling. Ice is contraindicated in venomous snake bites as it can cause more tissue damage. Remove constricting jewelry if indicated. For ALS, you want to intubate the patient if needed. Establish IV access. Administer normal saline via a IV fluid setup, but only if your patient is hypotensive. Monitor their EKG rhythm. Administer diphenhydramine, which is Benadryl, 25 to 50 milligrams, which is also 0.75 milligrams per kilogram for a child, either IV or IM, which is intramuscular. If indicated, such as them having hives, swelling, itching, or shortness of breath, administer albuterol, 5 milligrams for an adult or 2.5 milligrams if it's a child, by a nebulizer. But this is if the patient is wheezing, and you can repeat this every 5 minutes as needed. Administer methylprednisolone, which is also known as Solumedrol, at 125 milligrams or 2 milligrams per kilogram for a child via IV or IM for any patient with a bronchospasm, shortness of breath, hypotension, or airway edema. Administer epinephrine 1 to 1,000 IM 0.3 milligrams or 0.01 milligrams per kilogram if it's a child. If the patient is in anaphylactic shock with a hypotension and severe respiratory distress, be very cautious, again, for people that are 50 years old or greater, and for patients with a history of coronary artery disease or pregnant patients. This is a really big one. Consider IV epinephrine 1 to 10,000, which we would normally use for cardiac arrest, at 0.5 milligrams to 1 milligram or 0.01 milligrams per kilogram for a child, IV over 2 minutes, for severe life-threatening cases that are unresponsive to IM epinephrine. You can also administer norepinephrine 8 micrograms per minute to 12 micrograms per minute, IV, for severe anaphylactic cases with persistent hypotension. It's a very rare treatment, and it should only be reserved for patients with anticipated imminent cardiac arrest. So remember, This is kind of a last resort. We can consider IV epinephrine 1 to 10,000, 1 to 10,000 for IV epinephrine, or norepinephrine, but this is, again, a very last resort. Epinephrine may precipitate cardiac ischemia in the elderly or coronary artery disease patients. If an insect stinger is present, remove it by scraping it with the edge of a credit card or laminated ID badge. Do not use forceps to remove it, as you may inject further venom into the body if the stinger is pinched. It's best to remove the stinger as soon as possible while en route to the hospital to minimize the amount of envenomation from any residual stingers. Patients taking beta blockers may not show the usual tachycardia or anxiety often associated with anaphylaxis. An angioedema is swelling usually involving the lips, tongue, or oral pharynx. It is most commonly occurred after taking an ACE inhibitor medication. Airway compromise can quickly occur, and often prompt control of the airway is often necessary. Next up, we have altered mental status patients. So, there are many possible causes of altered mental status, which is a decreased level of consciousness, both medical and traumatic. For an altered mental status patient, it may be a manifestation of poor perfusion to all or part of the brain. For history, we want to gather, is there any possible suggestion that this may be caused by a differential diagnosis below, such as an evidence of a head trauma? What was the patient doing when the altered mental status began? For symptoms, we're worried about if a patient has a decreased level of consciousness, they may have a shortness of breath, weakness, seizure activity, chest pain, or fever. For a physical examination, we want to check if they have any head trauma. We want to check for unequal pupils, abnormal vital signs, abnormal neurological exams, and potentially a fever. However, they may be hypothermic with severe sepsis, so always check your basic vital signs. But we want to check these differential diagnoses. Do they have alcohol intoxication? Are we suspecting that they have a head trauma, such as a subdural hemorrhage, an epidural hemorrhage, a subarachnoid hemorrhage, an intracerebral hemorrhage, and diffuse axonal shear, which I have no idea what that means. For overdoses, are we worried about possible opioids, sedatives, hypnotics, or tricyclics? For toxic exposures, metabolic abnormalities such as high or low blood sugar, low oxygen such as hypoxia, high carbon dioxide, hypercarbia, low sodium, high calcium, high urea, high ammonia, which is a really big one, high or low thyroid levels, hypotension, which is shock, infection such as meningitis, encephalitis, and sepsis, cerebral vascular accidents such as a stroke, carbon monoxide poisoning, be careful with this, cardiac dysrhythmias, hypothermia, brain tumors, cerebral masses, seizures that are potentially postictal, hypertension, and psychiatric conditions. So you can see there's a lot of different ways that we can have an altered mental status. For BSI, we want to make sure that we have seen safety. Remember that changes in the mental status may be secondary to toxic exposures, such as carbon monoxide, so be very safe. Watch out for your ABCs. Consider an NPA and OPA if needed. High flow 2 is potentially necessary. Patients with an altered mental status must be on high flow oxygen via a non-rebreather mask. Assist ventilations with BVM as needed. Obtain vital signs. Physical restraints can be potentially utilized to provide you safety, but be really careful with this because it requires a lot of paperwork. Generally, we want to just talk down a patient. We don't want to do this unless absolutely necessary. Consider spinal motion restriction if the suspected traumatic etiology. Check their blood sugar. If their blood sugar is less than 70, administer oral glucose only if the patient is ANO times 4 and if they have an intact gag reflex, if they're able to swallow. Never administer it to an unconscious patient who can't protect their own airway. You'll end up causing them to choke and potentially die. Measure their SpO2 and refer to either diabetic emergencies, hyperthermia, seizures, strokes or CVA, and toxicological emergencies. For ALS, intubate the patient if necessary, but only if ventilatory depression is suspected to be the result of an opioid overdose. Establish an IV and administer Narcan or naloxone as described below prior to intubating the patient, because usually this can reverse it and we don't need to intubate somebody. Support them with a BVM until the naloxone can be administered. Consider intubation if the respiratory rate remains depressed after administration of naloxone. Monitor their EKG rhythm. If they have a dysrhythmia, treat it accordingly. Establish an IV with the patient who has an altered mental status. administer IV fluids. If they're hypotensive, if they're hypoglycemic, you can also consider dextrose or D10 if they can't take oral glucose. And you can also consider glucagon 1 milligram or 0.5 milligrams if it's a child intramuscularly. We can consider administering Narcan or naloxone 2 milligrams or 0.5 to 1 milligrams to a child, either IV, IO, or intraosseous, IM, or a MAD device, which is basically intranasal, for any possible suspicion of opioid overdose, including a small pupil size, slow respiratory rate, needle track marks, and an altered mental status. Naloxone can be repeated as necessary based upon the patient's responsiveness. And if you see an improved respiratory rate or improved level of consciousness, that's a good sign that the Narcan is working. We can give this up to a maximum of 6 milligrams, which may be needed for potent opioids. Obtain a 12 lead, and if indicated, get a 12 lead multiple times during this call. If the patient is not hypoglycemic and non-hypoxic, adult patients can potentially be extremely agitated and combative. If this is the case, and they're non-hypoglycemic and non-hypoxic, we can consider administering Versed or midazolam 1 milligram to 5 milligrams with a slow IV push, either that or intramuscularly or a mucosal atomizer device. And this can be used to protect the provider and the patient. Realize that midazolam may mask the altered mental status examination, and so we want to be very careful whenever we decide to use this. Check closely the pulse oximetry and also monitor their EKG, measure their blood pressure multiple times before and after you administer midazolam, and contact medical control if you have any questions about whether you should administer this or not. Consider administering sodium bicarbonate if the altered mental status is due to tricyclic antidepressants or TCA overdoses, including a widened QRS complex, hypotension, and seizures. Remember that patients who have alcohol in their breath may have other reasons that are causing the altered mental status besides the presumed alcohol intoxication, including head trauma, hypoglycemia, their postictal, or etc., like the differential diagnosis we described. Be aware of an altered mental status as a presenting sign of an environmental toxin or hazardous material exposure. Always think about your personal safety as well as others. Next up, we have atrial fibrillation or atrial flutter. And so, atrial fibrillation involves chaotic firing of the atrium, suspected clinically by an irregularly pulse, often caused by an underlying heart disease and or pulmonary hypertension. The patient won't have a visible P wave in lead 2 or V1 on the monitor. AFib by itself rarely causes hypotension. If AFib patients are hypotensive, always suspect another cause. Atrial flutter is a type of atrial dysrhythmia where the P flutter waves are usually found at a rate of 300 beats per minute. Typically, the ventricular rate will be slowed by the AV nodal conduction, typically a 2-to-1 block, giving a ventricle rate of around 150. The rate will usually not vary in comparison with sinus tachycardia, which usually varies over the course of several minutes. So, the history is heart disease, irregular heartbeats, pulmonary hypertension, and smoking. The symptoms involve palpitations, chest pain, shortness of breath, and lightheadedness or dizziness. For basic life support, there's not really much you can do. You can worry about airway, breathing, circulation. You can give high flow oxygen if indicated. Hypoxia may be an underlying cause of AFib. You can obtain vital signs, and you can also obtain their SpO2. However, for the ALS side of this, we can place a patient on a cardiac monitor, such as a 12 lead if the time allows, establish an IV access, administer IV fluid if they're hypotensive, and contact medical control if synchronized cardioversion is being considered. And we want to remember this is synchronized cardioversion. Well, it'll depend if a patient has severe shortness of breath, severe chest pain, or hypotension. For extremely unstable patients, medical control must be contacted. It must be prior to cardioverting an unstable patient with AFib or atrial flutter. The initial treatment for atrial fibrillation or atrial flutter is slowing the ventricle responses, IV fluids, beta blockers, calcium channel blockers, digoxin, and etc., not synchronized cardioversion. Synchronized cardioversion can potentially be dangerous in a patient with AFib due to the risk of an embolic event. The atriums are churning up blood. You're potentially developing a blood clot, and whenever you do this, you can cause it to travel upwards towards the brain, causing a stroke. This is caused by the fibrillating heart being converted back to a normal sinus rhythm and sending clots out of the atria into the left ventricle and out of the aorta. If synchronized cardioversion is requested, consider Versed or midazolam, 1 mg to 5 mg as a slow IV push or intramuscular or mucosal atomizer device, which is intranasal, prior to converting if the adult patient is still alert. Perform synchronized cardioversion for atrial fibrillation beginning at 120 joules, followed by 200 joules as needed. For atrial flutter, perform synchronized cardioversion beginning at 120, followed by 200 joules as needed. In children, use doses at 1 joule per kilogram and 2 joule per kilogram, respectively. You can consider adenosine or adenocard at 6 milligrams to 12 milligrams, or for a pediatric patient, it's pretty much the same ratio where you just go 0.1 milligram per kilogram to 0.2 milligram per kilograms of a rapid IV push. It won't be effective in converting AFib or atrial flutter, but it may show the ventricular response and help aid in identifying a rhythm that's unknown. Maybe it's a narrow complex tachycardia. If the monitor allows for increasing the paper's sweep speed, it can be increased from 25 millimeters per second to 50 millimeters per second. This may help in identifying the patient's cardiac dysrhythmia, although to be honest, I really don't know how to do this, but that's interesting. Cardioverting atrial fibrillation is still part of ACLS teaching, but probably should not be done much due to reasons mentioned above. Medical control should be contacted at first. So unfortunately for Annaville, we don't have Cardizem, and I've used it before, and I thought it worked great. Usually it's administered at 0.25 milligram per kilogram, then 0.35 milligram per kilogram, or maybe it's the other way around. It just depends on your local protocol, but we don't have access to it here. The next type of scenarios that we have is back pain. So for non-traumatic back pain, it's usually chronic, things like that, or it's due to some other reason. Anyway, for history, it's a patient that has a certain age group, past medical or surgical history, medications, onsets of pain, previous back injuries, the location of pain, you'd be worrying about that, fever, a history of kidney stones, which is big, a history of abdominal aortic aneurysms, a history of peptic ulcers, or pancreatitis. For the symptoms, we expect to see pain, swelling, extremity weakness, numbness, bowel, bladder dysfunction, syncope, which just means fainting, blood and urine, hematuria, they both mean the same thing, they're synonymous, melena, nausea or vomiting. If you want to see the type, the amount, if is it bloody or is it coffee grounds with any diarrhea or any vomiting. For the physical examination, we want to check for pain with palpation, pain with range of motion, and unequal pulses in the legs. So for BLS, all we're going to do is check ABCs, have section ready if necessary. We can apply oxygen if needed. We can obtain vital signs. We can place patient in a position of comfort, in a shock position if the patient is hypotensive. Keep the patient NPO, which is just a good practice in general. We never want to give something by mouth. Check the blood glucose if indicated. Check their pulse oximetry if indicated. Palpate the back for midline pain. If the patient is present with it, they should be placed in spinal motion restriction, even if no history of severe trauma, as it could represent osteopenia fracture or bony metastasis. So, even if there's no trauma involved, if you start palpating their back and they have a new onset of pain, you should place them in spinal motion restriction. That includes a C-collar and a backboard. For ALS, establish an IV access. Administer fluids if they're hypotensive. If they're acutely vomiting or actively vomiting, you can administer Zofran 4 milligrams for an adult or 2 milligrams for a child, IV or IM. If a renal stone is suspected, administer morphine sulfate 2 milligrams to 10 milligrams with a slow IV push or intramuscularly, or fentanyl 50 to 100 micrograms is needed for severe pain. Only administer morphine sulfate if the patient has a blood pressure greater than 100 millimeters per mercury. Watch the blood pressure and respiratory status closely and contact medical control for any questions. So, anytime we push a medication, we always want to have a 12 lead involved. This isn't really involved in here. This is just good, like a good rule of thumb. We always want a 12 lead. We always want to be monitoring their vital signs. We want to get their vital signs before and afterwards, especially for something like morphine sulfate where you can bottom them out. Note, for an abdominal aortic aneurysm or AAA, you must always consider if the patient is greater than 50 years old, especially if they have a history of hypertension. For kidney or urethral stones, they typically present with an acute onset of flank pain, which radiates around to the groin area. The patients may often complain of hematuria, and as you remember, that's blood in the urine, and they may vomit. They usually cannot stay comfortable in positions or writhing around in pain. Any new bowel or bladder incontinence, which means that they just can't make a bowel movement or they can't urinate properly, is a significant finding which requires immediate medical evaluation. An epidural spinal abscess must be considered in a febrile patient with back pain and a history of IV drug use. All right, so for bradycardia or symptomatic heart blocks, this protocol is for symptomatic patients only. It's only if they have an altered mental status, hypotension, severe chest pain, severe shortness of breath. It is not for patients in cardiac arrest, including PEA or pulseless electrical activity. The ACLS guidelines, or the Advanced Care Life Support Guidelines, define bradycardia as a heart rate that is less than 60 beats per minute. However, many normal people have a resting heart rate less than 60 beats per minute. Always remember to treat your patient, not a pulse rate. A heart rate less than 80 beats per minute in an infant is considered bradycardic, which is really important to note. The history is syncopal events, chest pain, altered mental status, shortness of breath, seizures, dizziness or lightheadedness, congenital heart disease, a patient on antiarrhythmic medications, a history of a cardiac pacemakers. You're going to see symptoms such as lightheadedness, dizziness, chest pain, shortness of breath, and palpitations. Now, some differential diagnosis can be a vasovagal event, like a syncopal event, medication overdoses such as a beta blocker, calcium channel blocker, clonidine, or digoxin, sepsis, cardiac conduction abnormalities such as an acute MI or an acute myocardial infarction, sick sinus syndrome, hypoxia, and acidosis. For basic life support, consider ABCs. Consider applying oxygen if the patient is symptomatic. You'll make it high flow. Always administer high flow oxygen to a patient or to a child with bradycardia, as bradycardia is usually the first manifestation of hypoxia in a child. Use a BVM if needed. Obtain vital signs, check their SpO2, and check a blood sugar. Hypoglycemia can cause hypothermia and bradycardia. For ACLS, if the patient is hypotensive or unresponsive, proceed with immediate transthoracic pacing. Never delay pacing in a symptomatic patient. Pace before an IV attempt in these symptomatic patients. Consider intubating the patient as necessary. Monitor an EKG rhythm and record a rhythm strip. Obtain a 12 lead if the time allows, and 12 lead EKGs are available. Skip the 12 lead and go into treatment below if the patient is unstable or severely bradycardic. Establish an IV access of normal saline if the patient is not hypotensive. If they are hypotensive, you can administer an IV fluid bolus at either 250 to 1,000 mLs. You want to maintain their systolic blood pressure to be greater than 100 millimeters per mercury. Use IV fluid with caution in patients with crackles or lung auscultations. So, we can administer atropine, 1 milligram or 0.02 milligram per kilograms for a child per minute. So we want to consider administering atropine 1 milligram at 0.02 milligram per kilogram if it's child, with a minimum dose of 0.1 milligrams to a max dose of 0.5 milligrams, IV or intraosseous, only if the patient is symptomatic. You can repeat at the atropine dose every 3 to 5 minutes as needed to 3 milligrams with the maximum of total atropine administered, or 0.04 milligrams per kilogram for a child as a maximum. Atropine is best used for sinus bradycardia, a first-degree AV block, and a second-degree type 1 AV block. However, if the patient is symptomatic with a second-degree type 2 heart block or a third-degree heart block, you may proceed directly to transthoracic external cardiac pacing at an initial rate of 80 beats per minute with 80 amps, I suppose. See Transthoracic External Cardiac Pacing Appendix, page 188. Transthoracic pacing should also be used in other bradydysrhythmias if there is no response to atropine. Use pediatric pacing pads in a child that's less than 15 kilograms. Administer midazolam or Versed at 1 milligram to 5 milligrams slow IV push. You can also use an intramuscular injection or a mucosal atomizer device if sedation of a conscious adult patient is needed during transthoracic external cardiac pacing. You can also consider norepinephrine at 8 micrograms per minute to 12 micrograms per minute IV in adult patients with persistent hypotension, unresponsive to IV fluid boluses, atropine, or transthoracic pacing. And you want to maintain their systolic blood pressure greater than 100 millimeters per mercury. If a patient is bradycardic and asymptomatic, it is not necessary to treat the bradycardia. Never treat an idioventricular escape wide complex bradyodysrhythmia with lidocaine. This may cause the patient to go into asystole, so be very careful if they have an idioventricular rhythm. The administration of atropine to a bradycardic acute MI patient will increase the heart rate and thus may increase the myocardial oxygen consumption. This could increase the size of the infarct and cause a worsening damage to the heart. Patients with a history of heart transplant in a second-degree type 2 or third-degree heart block will usually not respond to atropine. Go directly to transthoracic external cardiac pacing if the patient is unstable. Always consider the early application of transthoracic pacing pads in elderly patients, bivascular blocks, and those suspected of having an acute MI or myocardial infarction. Transthoracic pacing must also be started for hemodynamically unstable patients who are awaiting IV access, so just don't delay it. Higher doses of atropine greater than 3 milligrams IV total may cause paradoxical bradycardia unless treating a suspected organophosphate poisoning. So if you do give more than 3 milligrams IV and you're not treating an organophosphate poisoning, expect the bradycardia to potentially get worse. Elevated intracranial pressure, such as Cushing's response, and abdominal trauma, which is hemoperitoneum, may cause bradycardia. The majority of pediatric arrests are always due to airway problems. Bradycardia in a child is usually the result of hypoxemia and hypoventilation. Make sure a good airway is established. Bradyodysrhythmias are the most common pre-arrest rhythms in children and need immediate attention. So we always want to consider airway if a child is bradycardic. Always consider hyperkalemia in a patient with a wide complex bradycardic rhythm. PALS, or Pediatric Advanced Life Support, recommends epinephrine before atropine. Atropine does not have much effects on infants less than 6 months old and a decreased effect on a child that's less than 4 years old. For chest pain patients, there are multiple causes of chest pain, including cardiac regarding angina, myocardial infarction, and aortic dissection. There's pulmonary, such as the pneumothorax, a pulmonary embolus, pneumonia, and pleurisy. There's musculoskeletal, there's psychiatric, and there's GI-related issues such as reflux, hiatal hernias, and peptic ulcer diseases. So, for acute myocardial infarctions and pulmonary emboluses that are most significant should always be considered. For myocardial ischemia, it's still reversible myocardial damage, and it's chest pain that usually lasts 30 minutes or less in duration. For a myocardial infarction, it's irreversible myocardial damage, death of cardiac tissue or heart tissue due to insufficient blood flow from the coronary arteries, and it's chest pain that's usually greater than 30 minutes in duration. The treatment goal of a suspected MI or myocardial infarction is coronary revascularization, thrombolytic therapy, or angioplasty as soon as possible. For history, we want to gather OPQRST, the history of the coronary artery disease, positive family history, hypertension, diabetes mellitus, tobacco use, an age greater than 55 years old, elevated cholesterol, pulmonary embolus risk factors, use of erectile dysfunction medications. For symptoms, we're looking for chest pain. It may be epigastric, or tightness across the chest, shortness of breath, nausea, vomiting, diaphoresis, palpitations, coughing, and weakness. For physical examinations, we may be looking for things like JVD or jugular venous distension, abnormal breath sounds, pedal edema, unilateral calf pain, pain on palpation of chest wall, or epigastric pain. Now for BLS, we're just really worried about the same thing we've always been worried about. ABCs, we're worried about applying oxygen if necessary. The main goal is to improve oxygenation at the myocardial tissue level, so you consider high flow, obtain vital signs, and establish pulse oximetry or a room SpO2. Now, for the ALS side, we want to maintain airway as needed. We want to monitor EKG rhythms. If available and time allows it, establish a 12 lead as early as possible. If an inferior and or a posterior acute myocardial infarction is indicated, perform a right-sided 15-lead EKG if time permits. If ST segment's elevation is presented in lead V4R, or the right side, use extreme caution administering nitroglycerin. These patients will need a good preload to maintain their blood pressure. Do not, whatever you do, do not administer nitroglycerin unless the IV has been started and a 1,000 milliliter bag has been started. Ideally, the systolic blood pressure should be greater than 140 millimeters per mercury in a right ventricular infarct patient before administering nitroglycerin. So these 15 lead EKGs, they're kind of tricky to learn to set up, but really you're just messing with the V4, 5, and 6, and that's something that I'll talk about at another day. But you should always look this up if you're not familiar with it. Now, establishing IV access of normal saline, establishing an IV, especially if given nitroglycerin, is important. And ideally, IV access should be initiated before you administer that drug. Just get an IV set up, start flowing saline before you start administering nitroglycerin. Administer IV fluid bolus, we already talked about that. For nitroglycerin, if you're going to administer it at 0.4 milligrams sublingually or a spray every 5 minutes for up to 3 doses in total, which is going to end up being 1.2 milligrams in total. If the patient is having a suspected active cardiac chest pain event and the systolic blood pressure is greater than 100 millimeters per mercury. Nitroglycerin should still be administered even if the patient has taken his or her own. Monitor the patient's blood pressure very closely. If the systolic blood pressure falls greater than 50 millimeters per mercury, do not administer another nitroglycerin unless approved by medical control. Do not administer nitroglycerin if the patient is taking sildenafil, which is Viagra, tadalafil, Cialis, or vardenafil, Levitra within previous 24 hours. That's a huge contraindication. Nitroglycerin administered to a patient on an erectile dysfunction medication can cause irreversible and fatal hypotension. Administer aspirin if the person is not allergic to it, is not pregnant, and cardiac chest pain is suspected. The aspirin can be administered as 4 81 milligram baby aspirins, 324 milligrams, or 1 325 milligram aspirin. Have the patient chew and swallow it. Do not administer if the patient has taken aspirin within the past 6 hours, unless more aspirin is needed to reach the 324 milligram max. So, administer morphine sulfate, 2 milligrams or 10 milligrams, a slow IV push, or fentanyl, 50 to 100 micrograms as needed for patients who have persistent chest pain and are unresponsive to 3 sublingual nitroglycerin sprays. Only administer morphine if the patient has a greater than 100 systolic blood pressure, and watch the blood pressure and respiratory status closely. Administer Zofran 4 milligrams IV or IM if it's an adult patient as needed for active vomiting. Contact medical control if the patient is suspected to have symptomatic chest pain as a result of recent cocaine use for a possible diazepam or Valium 5 milligram to 10 milligrams slow IV push order. Treat the cardiac dysrhythmias with the appropriate protocol as indicated. Establish a second IV site depending on the patient's severity. Now note, you want to transport the patient to the closest appropriate cardiac hospital, unless ordered otherwise by medical control or transferring a physician. It is realized that some interfacility transports, including satellite clinics, may involve the patient with active chest pain that have already been examined by a healthcare provider at that clinic or a hospital. In these interfacility transport cases only, it will be the discretion of the transferring physician as to which hospital the patient should be transported to. Ideally, in patients with suspected MIs or myocardial infarctions, the most experienced person should be establishing the IV to hopefully limit the number of attempts. If subsequent thrombolytics are given, it will dissolve all clots, and any IV attempt sites may bleed extensively, so be careful with how much IVs you try to establish. Administer IV fluid boluses if the systolic blood pressure is less than 100 millimeters per mercury. Remember that the chest pain may be atypical, even absent in diabetic patients. They may have a silent MI because they have a lack of response to their nervous tissue just due to the unwrapping of the myelin sheath from blood sugar over time. And they may be atypical in females and the elderly. Weakness is fairly common of an acute myocardial infarction in the elderly. With a cardiac ischemia or infarction, time is muscle. A short scene time with rapid transport is essential. Lead 2 only detects inferior MIs. Do not be misled by any lack of ST elevation on the monitor, as the patient could still have an anteroseptal or lateral MI, which will not cause ST elevation in lead 2. Obtain a 12 lead on all suspected cardiac chest pains. Transmit the 12 lead to the receiving hospital if the time allows and if the monitor is able to. A one-time dose of aspirin may still be administered to patients on warfarin, Coumadin. The aspirin is administered to suspected cardiac ischemic patients for its antiplatelet effects, since it's not a blood thinner. Patients on Coumadin may need an explanation of this before agreeing to have aspirin administered to them. Do not administer nitroglycerin to a pregnant patient. Do not administer it to a pregnant patient. Remember this. Many patients having an MI or an inferior MI are very sensitive to nitroglycerin and may have a large drop in blood pressure. If the systolic blood pressure falls by greater than 50 millimeters per mercury after nitroglycerin, do not administer another nitroglycerin unless first approved by medical control. Instead, treat the patient with aggressive IV fluids to improve preload and cardiac output. Up to 50% of patients with an acute inferior myocardial infarction will have profound hypotension after the administration of nitroglycerin due to its preload reduction. Consider pulmonary embolus in a patient that has a history of tobacco use, prolonged travel or bed rest, lower extremity immobilization, recent pelvic surgery, history of deep vein thrombosis, or oral contraceptive use. Always ascertain if the patient has taken any erectile dysfunction medications within the last 24 hours, and administering nitroglycerin to these patients who have used them can have irreversible and fatal hypotension. For diabetic emergencies regarding hypoglycemia or hyperglycemia, in this protocol book, hypoglycemia is defined as any blood glucose measurement less than 70. For hyperglycemia, it's defined as any blood glucose measurement greater than 250 units. The word dextrose and glucose will be used interchangeably throughout this manual. Now for history, any history of diabetes, diet-controlled oral agents or insulin, has patients missed their meds? Has the patient taken their meds but have not eaten? Do they have history of chills or fever? Do they have an altered mental status? And do they have a family history of diabetes? The symptoms of hypoglycemia: do the patients look like they had a stroke? Patients may have an altered mental status, pallor, diaphoresis, which is just sweating, tachycardia, or seizures. They can even have focal neurological findings. Symptoms of hyperglycemia, or DKA, diabetic ketoacidosis. Patients look dehydrated. They have hot, dry skin, polyuria, which is increased urination, polydipsia, increased thirst, nausea or vomiting, abdominal pain, and weakness. For a physical examination, these patients will generally have an altered mental status, diaphoresis, a fruity odor on their breath, known as acetone, rapid deep respirations, known as Kussmaul respirations, tachycardia, hypotension, hypothermia, and a medical alert tag. For basic life support, you always want to do the same thing pretty much every single time. You want to watch out for airway, breathing, circulation, apply oxygen if necessary, use a BVM if necessary, obtain vital signs, check their blood glucose. If their blood glucose is less than 70 and they're able to swallow with an intact gag reflex, their ANO times 4, you can administer oral glucose 15 grams to 30 grams or 10 grams if it's a child. The oral glucose may be repeated in 15 minutes if no response and the patient is still able to protect their own airway. Also, measure their SpO2. Now, if you're an ALS unit, you want to establish an IV access, and then afterwards you can administer saline if necessary if the blood sugar is elevated greater than 250 units and the patient is showing signs of hyperglycemia. It can cause dehydration or hypoperfusion. So basically what that means is if you have a patient who has an elevated blood sugar, you can administer saline. That's a useful thing to do. Monitor the patient closely for signs of fluid overload. Reduce the IV fluids if the patient is a dialysis patient. If the patient's glucose is less than 70 and they're symptomatic, administer D10, which is 25 grams of IV fluid of dextrose, or 0.5 grams per kilogram to a child. You may repeat the 250 milliliters of D10 in 15 minutes. If the blood glucose measurement is still less than 70 and the patient remains symptomatic, if IV access cannot be obtained and the symptomatic patient has a glucose less than 70, Administer glucagon 1 gram or 0.5 milligram or for a child with an intramuscular injection. Oral glucose preparations may be used if the patient is only mildly symptomatic and able to swallow, i.e., they can protect their own airway. Monitor EKG rhythms, obtain a rhythm strip and a 12-lead EKG if the time is available, and ideally, all hypoglycemic patients who receive intravenous D10 in the field should be transported to the ER. At an absolute minimum, patients who are found to be hypoglycemic prior to D10 must eat a high-starch meal and must be left in the presence of a responsible family member or friend who can stay with the patient for the minimum of 6 hours. They must be educated on the signs and symptoms of hypoglycemia, and they must be instructed to monitor the patient closely. In addition, the family member or friend remaining with the hypoglycemic patient must sign as a witness on the patient care report. For these kind of patients, make sure you focus or emphasize on patient education. It's really important for these kind of calls. Now note, often hyperglycemic patients who have been compliant with their insulin have an underlying source of infection or stressor causing increased blood glucose levels. The pre-hospital treatment of hyperglycemic patients is IV fluids, and if the patient can tolerate it, insulin will be administered later in the emergency department. Alcoholic patients frequently present with hypoglycemia, poor glycogen liver stores, check a glucose determination on a patient with evidence of alcohol intoxication and altered mental status. Sodium bicarbonate is no longer used in the treatment of elevated blood sugars, possible metabolic acidosis in the pre-hospital setting. Due to the long half-life of many oral diabetic medications, there may be a delay and prolonged reoccurrence of their hypoglycemia. This is especially true on oral diabetic medications that have been taken in a suspected overdose or in a pediatric patient. These patients are often admitted to the hospital for close monitoring of the blood glucose levels. The glucometer readings may be inaccurate by about plus or minus 30 units. Always treat a possible hypoglycemic patient if they are symptomatic and their blood sugar is within 80 units. For glucagon, it's to be used for a patient in which IV access can't be established whenever you're trying to administer D10. In most situations, glucagon should be administered before going to the EZ-IO on a hypoglycemic patient. Glucagon will not work as fast as D10 and sometimes will not work as well on them, depending if they have depleted glycogen stores. Basically, what this is saying is first we try to establish an IV for D10. If that doesn't work, we can move to glucagon intramuscularly. If that doesn't work for whatever reason, then we can move over to an intraosseous establishment where we set up an IO on a patient and administer a D10 through their bone. In the event that a hypoglycemic patient requires a second 25 grams of D10 in order to elevate the blood glucose levels, the patient should be transported to the hospital. Any exceptions to this must be discussed with medical control. So if they require a second round of D10, you must transport them. There's no exception. You can talk to medical control. I suppose that is the exception, but you should always transport them. Not transporting a hypoglycemic patient is one of the most high-risk situations for an EMS service and fire department. Always be cognizant of that fact. For environmental emergencies, this protocol will cover animal bites, snake bites, insect bites, electric shocks, lightning strikes, heat-related emergencies like hyperthermia, hypothermia, and near drowning. For BLS, for animal bites, snake bites, and insect bites, make sure that you establish scene safety. Make sure that the subject dog, animal, snake, etc. is not nearby. Check their ABCs. Apply oxygen. If there's a snake bite that's suspected, keep the patient as still and calm as possible. Immobilize a bitten extremity and keep it at a lower heart rate or lower level than the heart. If the snake is dead, it can be safely transported with the patient. Bring it to the emergency department to aid in identification. Remember, a dead snake can still inject venom if handled carelessly. The use of constrictive bands or tourniquets is not recommended for venomous snake envenomations. Clean and bandage any wounds as needed. Now you want to apply ice to insect or animal bites to decrease swelling. Ice is contraindicated in snake bites. It results in more tissue damage. Refer to the allergic reaction and anaphylaxis protocol as needed on page 23. For pulse oximetry, measure that as needed. Mark the edge of the swelling with the pen and note the time directly on the skin next to its edge. Remove any jewelry that may be affected. We don't want the swelling to cause the jewelry to cut off circulation somewhere. For ALS or advanced life support, You want to monitor an EKG rhythm. Establish an IV on an uninjured, non-bitten extremity. Administer IV fluids as necessary. If the patient shows hypoperfusion, you can use a 1,000-liter bag. Administer morphine sulfate, 2 milligrams to 10 milligrams, or 0.1 milligram per kilogram to a child via a slow IV push or intramuscularly, or you can administer fentanyl 50 to 100 micrograms if the patient is having severe pain. You can administer diphenhydramine or Benadryl at 25 milligrams to 50 milligrams, or 0.75 milligrams per kilograms intramuscularly or IV as needed for swelling or itching. Administer Zofran 4 milligrams or 2 milligrams for a pediatric patient via IV or intramuscularly as needed for active vomiting. Administer methylprednisolone or Solumedrol at 125 milligrams or 2 milligrams per kilogram for a child, IV or IM, in a patient having a significant allergic reaction to his or her bite or sting. Now, some very important notes. Crotolid, I have no idea, crotolid snake venom is an anticoagulant. At the site of a poisonous snake bite, there will usually be an echomyosis, pain, swelling, redness, numbness, or puncture marks. Patients often will have nausea or vomiting and may complain of a metallic taste in their mouth. Up to a third of poisonous snake bites do not result in envenomation. They're known as dry bites. Movement expedites the spread of venom. Keep the patient's physical movement to a minimum. Do not let the patient walk. Provide calm reassurance to the patient. Do not apply ice to the snake bites. If a patient has been bitten by an animal, animal control needs to be notified. This can be done via a family member at the scene or done later by the parent or the patient's guardian at the hospital. If the patient is not transported, make sure that the patient knows to contact medical control or have Metrocom notify animal control directly. Metrocom is like talking to fire dispatch, basically. Black widow spider bites are minimally painful at first, but after a few hours of progression can cause severe abdominal pain. Brown recluse spider bites are minimally painful initially, but tissue necrosis just means the death of tissue at the site of the bite may develop over the next few days. If an insect stinger is present, as we talked about earlier, remove it by scraping it with the edge of a credit card or a laminated ID badge. Do not use forceps to remove it, as they may inject further venom into the body if the stinger is pinched. It is best to remove the stinger as soon as possible while en route to the hospital to minimize the amount of envenomation from any residual stingers. For jellyfish or Portuguese man-o'-war envenomations, to prevent further injury to the patient, the following decontamination steps are important. We can use a meat-based tenderizer, such as Aldose, and it can be mixed with rubbing alcohol if available or warm water to make a paste that can help inactivate the nematocyst by breaking down the proteins found in jellyfish toxins. Gently scrape the site with a credit card or a tongue depressor covered with this paste to remove any tentacles or nematocyst still on the skin. Remnants of the nematocyst are usually still present on the skin even if they can't be seen. Never apply fresh water or ice to the sting area or the stung area. Detached live tentacles should be treated with extreme caution, as envenomation may still occur for several hours. True allergic reactions are rare, but hyperventilation due to severe pain and anxiety is common. For stingray envenomations, clean the puncture site as normal standard of any wound care, and as soon as possible, immerse the bitten area in hot water, as hot as the patient can tolerate without actually getting burned, around 110 degrees if possible. But where do we get this hot water, right? As the stingray toxin is heat labile and is inactivated by heat. The water will need to be exchanged for more hot water as it cools. The immersion duration of 30 to 90 is completed at the hospital. It is best to transport these patients or have them seek immediate physician follow-up due to the potential of a retained barb, tetanus status, and infection potential such as Vibrio, which is like the flesh-eating bacteria, and etc. You can administer morphine sulfate 5 milligrams IV or IM or fentanyl 50 to 100 micrograms to a patient experiencing severe pain. Now, for electric shocks or lightning shocks. For BLS, you want to establish scene safety, have dispatch get the electric company as needed, make sure no patient is in contact with the electrical source before touching the patient. Apply an AD if indicated. Watch out for ABCs. Apply oxygen. Assist ventilations with the BVM. Consider C-spine precautions as needed. And obtain vital signs. That's a really big one, is watch out for spinal motion restriction. For a physical examination, look for the entrance and exit wounds of the electricity passing through the organs. And watch out for burns and altered mental status. Decreased hearing, which can be caused from a ruptured eardrum. Musculoskeletal dislocations, such as a posterior shoulder dislocation. For ALS, watch out for their airway, intubate them as needed. Monitor an EKG rhythm. You should always get a 12 lead. That is insane if you don't get a 12 lead on these patients. Electric shock and lightning strikes cause a high incidence of cardiac dysrhythmias. Go to the appropriate dysrhythmia protocol as needed. I believe it's around page 70 or so. Establish IV access. Administer IV fluids as needed. Intravenous fluids help prevent rhabdomyolysis, which is skeletal muscle breakdown that can cause renal failure. Administer morphine sulfate between 2 to 10 milligrams or 0.1 milligram per kilogram for a pediatric patient. That's a slow IV push. Or you can do this by administering fentanyl 50 micrograms to 100 micrograms as needed for severe pain control. Note, for an electric shock of an alternating AC or household current, they tend to cause ventricular fibrillation, while direct currents, such as a DC or a battery or lightning, tends to cause asystole, which we will talk about later. Do not handle down power lines until the power company has de-energized the lines. Do not get too close, as currents can be transmitted through the ground and cause the power lines to suddenly whip around. Down power lines in contact with a vehicle usually pose no threat to a victim in the car, as long as the victim makes no attempt to get out of the vehicle. Reassure the victim from a safe distance until it's safe. Don't become part of the call. Tell them to stay in their car and wait until we can talk to the power company and they can DC any electrical lines. Next, for heat-related emergencies such as hyperthermia, some history, we can watch out for medications such as anticholinergics, antipsychotics, tricyclic, antidepressants, beta blocker, aspirin, drugs such as cocaine, amphetamines, work-related physical activities such as exercise-induced, history of sun or heat exposure. We want to watch out for symptoms such as cramps, dizziness, nausea, or vomiting, or syncope, which again just means passing out. For basic life support, we want to watch out for ABCs, apply oxygen, place the patient in a cooler environment and remove the patient's clothes, use a cold water sponge bath and cold wet towels with fanning as needed. Evaporation by fanning is very effective. Ice packs may be needed to be placed in the axilla, the groin, and the back of the neck until shivering occurs. Obtain and monitor the patient's temperature if a thermometer is available. Obtain vital signs, check their blood glucose levels, and obtain an accurate list of the patient's medications. Some of them may worsen hypothermia. Now, you also want to check out their SpO2, and if the patient is awake with an intact gag reflex, administer oral glucose via, or oral fluids, sorry, not glucose, such as water, Gatorade, etc. For ALS, you want to intubate the patient as needed, monitor an EKG rhythm, get a 12 lead, establish IV fluids. You want to give them saline, and if available, administer IV fluids of a cold normal saline to any adult hyperthermic patient that has a neurological change. Cold IV fluids need to be avoided in children, however, as the cold IV fluids may result in too rapid of a drop in body temperature with counterproductive shivering, okay? So adult hyperthermic patients that have a neurological change or an altered mental status, we give them cooled saline, which we do have access to. Do not do this for children, though. And we think about febrile seizures at this point, right? So, administer Zofran, 4 milligrams or 2 milligrams to a child, IV or IM, if the patient is vomiting, which is common in heat emergency patients. Administer diazepam or Valium, 5 milligrams to 10 milligrams or 0.2 milligrams per kilogram to a child with a slow IV push if the patient has severe shivering. Consider infectious diseases such as meningitis or pneumonia in all cases of heat-related illnesses and use proper OSHA equipment as necessary. You want to watch out for heat cramps, which can then lead to heat exhaustion, and then heat stroke, which is an entire spectrum of symptoms. Historically, heat exhaustion involves a sweating patient, while heat stroke involves a non-sweating patient. However, the definition of heat stroke involves an altered mental status, a seizure, or a coma, regardless of whether the patient is sweating or not. Usually, the very young infants, is very big, and very old are the most likely affected by heat-related emergencies. Do not overcool a hyperthermic patient. If shivering occurs, stop cooling methods and lightly cover the patient. Shivering will generate an enormous amount of heat in the already hyperthermic patient, so we're just being counterproductive. For hypothermia patients, for mild hypothermia, it's defined as a core temperature below 90 to 95 degrees Fahrenheit. Patients often will have an altered mental status and uncoordinated intense shivering. Severe hypothermia will be less than 90 degrees Fahrenheit. So mild is between 90 and 95. Severe is less than 90 degrees Fahrenheit. Patients usually will have a profound lethargy or a coma, a slow or absent pulse, hypotension, and a decreased respiratory rate. These patients may have a history of cold water submersion, drugs, or alcohol ingestion, fall with the inability to get up, and exposure to the environment, as well as sepsis. We want to watch out for patients who have fatigue, confusion, and nausea. For ABCs, we want to check out, for BLS, we want to check out their ABCs, check a respiratory rate and pulse for 30 seconds, as these patients are generally profoundly bradycardic. Avoid rough handling of the hypothermic patient, as they can have a sensitive myocardium, which means a sensitive muscular heart tissue. Begin CPR if no pulse is detected and the patient is without obvious signs of death, such as dependent lividity or rigor mortis, and some other options too. Apply high flow O2, use warm oxygen if available, and assist with the BVM as needed. Check vital signs. Check the patient's temperature if available. However, most standard thermometers will not register below 94 degrees Fahrenheit. Check a blood glucose level. Always check for a blood sugar in a suspected hypothermic patient, as many hypothermic patients are hypoglycemic also. Treat hypoglycemia as indicated in page 37. Remove the patient's wet clothes and dry them thoroughly. Cover the patient with dry blankets, covers, or other insulating materials. Move the patient to a warmer environment, such as the back of the ambulance, and establish pulse ox. Now, for ALS, or in regards to it, we want to intubate as necessary, monitor a 12 lead. The patient may have an elevated ST segment, a J point elevation on the EKG, known as the Osborne wave. Extremely cool. In addition, the patient may have all kinds of dysrhythmias present. Proceed to particular dysrhythmia protocol as needed. Obtain a 12 lead if the time allows. Establish an IV and administer saline if necessary. It's best to give them warm normal saline if possible, using a vehicle's heater, and use caution to avoid overheating the IV fluids. You can administer D10, 25 grams of it, or 0.5 grams per kilogram in a child IV, or Narcan or naloxone, either 2 milligrams or 1 milligram for a child IV, IM, or mucosal atomizer device as needed. If the patient is in cardiac arrest, administer 1 to 10,000, 1 milligram or 0.01 milligram per kilograms IV. Defibrillate at 200 joules or 2 joules per kilogram for a child if the patient is in VFib. Continue CPR and do not repeat ACLS medications or further defibrillations until the patient is warmed above 85 degrees Fahrenheit. Medications will not work in hypothermic tissues. If the core temperature is not known, err on the side of giving the ACLS medications and continue the proper dysrhythmia protocols. Continue CPR as needed. And cardiac pacing of bradycardic dysrhythmias is usually not indicated unless the bradycardic patients persist after rewarming. External cardiac pacing should not be performed in a patient with a temperature less than 86 degrees Fahrenheit. Now note, the severely hypothermic patient is usually unresponsive to most cardiac medications, defibrillation, and external cardiac pacing. The best treatment in a severely hypothermic patient, or a cardiac arrest patient, is CPR, oxygenation, and rewarming. It is important to be gentle in the movement of hypothermic patients to avoid precipitating ventricular fibrillation. The extremes of age, young and old, are more susceptible to hypothermia. Now for near drowning. The introduction, for their history, it's a length of submersion, approximate temperature of the water. We want to watch out for crackles and an altered mental status. For basic life support, we want to allow appropriately trained rescuers to remove the victim from any areas of danger. Drowning is a leading cause of death among the would-be rescuers, so be very careful. Don't just jump in and try to save them because you'll become part of the problem very easily. Watch out for ABCs, suction as needed, apply oxygen, assist ventilations with the BVM as needed, and start CPR as needed. Strict C-spine motion restriction should occur. A significant number of near-drowning patients involve injuries to the C-spine due to diving accidents. Spinal precautions must be taken at all stages of rescue and resuscitation. Spinal motion restriction, if a spinal injury is suspected, must be done. If possible, determine the submersion time. You just talk to a bystander. Okay, someone had to call 911, right? Remove wet clothes and dry the patient as needed. Cover them to prevent heat loss. Establish a pulse ox. And refer to spinal motion restriction appendix as needed in page 183. Oh, brother, we're on page 44. For ALS, intubate the patient as needed. Monitor a 12 lead. Establish IV access of normal saline. Administer IV fluids of normal saline as needed and proceed with ACLS protocols. Note, always consider a spinal cord injury in a near drowning patient. Use spinal motion restrictions in all unconscious patients. In a recent cold water near drowning, always err on the side of attempting resuscitation. These patients have a possible chance of survival. All near drowning patients should be transported to the hospital because there's a significant percentage of patients that will develop a delayed respiratory distress over the next several hours. So even if we save them, even if they say, I'm okay, I don't need to go to the hospital, push it as hard as you can for them to go to the hospital because they need to go for this potential delayed respiratory distress. Next up, we have excited delirium. So this protocol is intended to provide EMS personnel with chemical-assisted restraints in adult patients who otherwise could not be safely restrained by conventional measures. Always protect yourself when dealing with combative patients. Have law enforcement respond to the scene as needed. Excited or agitated delirium is a life-threatening medical emergency. It's not a crime in progress, and patients exhibiting signs of excited delirium require immediate supportive care. We want to protect these guys. We also don't want to get beat up by them, so make sure to contact PD to help establish scene safety. The history is a bizarre, agitated behavior. It's hyperactivity, often incomprehensible sounds, incoherent shouting, restless, often in various signs of undress, extreme paranoia, unexpected strength. That's a really big one. History of drug ingestion, such as cocaine, amphetamines, and synthetic marijuana. A history of psychiatric illness, non-compliance with psychiatric medications. The symptoms include bizarre thought content, hallucinations, restlessness, chest pain, anxiety, shortness of breath, agitation, moving towards bright lights or headlights, or shiny objects such as mirrors. Rapid changes in emotion, easily distracted, they have a lack of focus, decreased awareness and perception, and a lack of sensation to pain. They may act crazy or have unusual effects. They can have hypertension, dilated pupils, rapid breathing, foaming at the mouth, tachycardia, disoriented. They could have diaphoresis and an elevated temperature. So for BLS, we want to confirm scene safety and ensure a protective environment for yourself and the patient. Law enforcement should be called for assistance in difficulty or potentially dangerous situations. Make sure that the dangerous situation or the dangerous object, such as knives, guns, pills, etc., are removed before making patient contact if possible. Establish a rapport with the patient and constantly reassure the patient. Don't leave them alone unless it's necessary for personnel safety. If the person allows it, obtain vital signs. If restraints are required to protect the patient and the EMS provider, only authorized restraints such as commercial, soft leather, or other soft materials such as Curlex, sheets, triangular cravats, etc. are to be used. Look at patient restraint appendix on page 169. If the patient is handcuffed by law enforcement, it is expected that they will accompany you and the patient in the ambulance or follow the ambulance to the hospital. Never restrain patients prone face down on the stretcher. You can use mask or face shields and apply them to patients threatening to spit. Apply oxygen if the patient is lethargic or has unstable vital signs. Check their blood glucose levels. Administer oral glucose 15 grams to 30 grams by mouth if it's less than 70 and the patient has an intact gag reflex. Check the pulse oximetry and check temperature. This is extremely important. If it's elevated, begin cooling method such as ice packs, tepid water fanning, etc. For advanced life support, monitor the EKG rhythm if possible on a diaphoretic agitated patient. Establish IV access and administer 1,000 cc's of fluid. Administer midazolam or Versed 1 to 5 milligrams via a slow IV push. That's 2 milligrams to 5 milligrams intramuscular or mucosal atomizer device. Those are just the other two options if you can't do an IV push. To control an extremely agitated patient, or to treat hyperthermia in an excited delirium patient. The patient must be on oxygen and the pulse-ox must be used if midazolam is used. Use the IV route if it can be established safety, and the IM, or the intramuscular, and the mucosal atomizer device, or the intranasal, route may be preferred in these combative patients. Administer Narcan or naloxone, 2 milligrams IV, IM, or MAD device, and or D10 if indicated. Continually reassess this patient or your patient and monitor the airway closely. Note, excited delirium is a medical emergency with a mortality rate of 10%. These patients need to be transported quickly to the ER and will need early administration of midazolam or Versed. Never forget to measure a blood glucose, that's so big, and pulse ox on a combative patient. They may be hypoglycemic or hypoxic, especially for alcoholic patients. Paramedic personnel may utilize the mucosal atomizer device as an alternative drug delivery adjunct for patients without IV or IO access who require the urgent administration of midazolam or Versed, and you can see more in protocol page 152. For a hypertensive crisis or a hypertensive emergency, a hypertensive crisis or emergency involves a systolic blood pressure greater than 220 units and a diastolic blood pressure greater than 110 units, and, it's not or, it's and, signs and symptoms of central nervous system dysfunction, usually stroke-like symptoms. There's no need to treat asymptomatic hypertensive patients unless they have one of the below symptoms. If the patient has elevated blood pressure without any symptoms, there's no need to treat this hypertensive reading in the pre-hospital setting. Acute lowering of the blood pressure may actually cause further harm to the patient by underperfusing end organs. For the history, a history of hypertension or stroke, a CVA. Is the patient taking blood pressure medications? Do they have increased stressors? Do they have coronary artery disease? Do they use a drug like cocaine? Did they use any erectile dysfunction medications? If they're in the third trimester of pregnancy up to 2 weeks postpartum, which means 2 weeks afterwards, refer to the OB emergencies, preeclampsia and eclampsia on page 56. For symptoms, watch out for an altered mental status, a headache, epistaxis, which is just a nosebleed, blurred vision, dizziness, severe chest pain, severe shortness of breath, and seizures. For our physical examination, watch out for strong pulses, crackles, focal neurological deficits, an altered mental status, and neck stiffness, also known as nuchal rigidity. For BLS support, watch out for your ABCs, apply high flow O2 if necessary, they have shortness of breath or an altered mental status. All symptomatic patients with a hypertensive emergency should be transported in a semi-Fowler position. Obtain vital signs, make sure the blood pressure cuff is the correct size, it's always good to check it on both arms. Check your blood glucose levels and treat as appropriate, and monitor a pulse oximetry. For ALS support, you want to monitor a 12 lead if the time allows for it. Establish an IV access. There's no need to administer IV fluids to a hypertensive patient, but you do want to have IV access. You can consider administering labetalol, also known as Normandin. It's 10 milligrams to 20 milligrams. It's a slow IV push over 2 minutes. If the patient has either a systolic blood pressure 220 units or a diastolic blood pressure 120 units and severe chest pain, severe headaches, or an altered mental status. So it has to have one of these and these. Monitor the blood pressure closely and check and record the blood pressure before administration of labetalol. Do not administer this patient labetalol if the patient has a history of recent cocaine ingestion, less than 6 hours, and has a history of severe asthma, or if the patient has had any wheezing on the exam. Make sure you inform the emergency department staff that labetalol was administered to the patient in the field. Administer diazepam, Valium, 5 milligrams to 10 milligrams with a slow IV push as needed for seizure activities. The patient is in the third trimester of pregnancy up to 2 weeks postpartum, which is 2 weeks afterwards. Refer to preeclampsia and eclampsia protocol on page 56. Administer Zofran 4 milligrams if it's an adult patient and if they're having active vomiting. Transport the patient in a position of comfort and reassure an anxious patient. Contact medical control if the patient is having a suspected drug-induced symptomatic hypertension, such as cocaine, for possible Valium or diazepam, same thing, 5 milligrams to 10 milligrams with a slow IV push order. Once again, Asymptomatic hypertensive patients do not require treatment in the pre-hospital setting. Never treat an elevated blood pressure on just one set of vitals. If any doubts exist whether to treat with labetalol or not, contact medical control. The blood pressure should not be rapidly lowered in a patient suspected of having transient ischemic attacks or TIA or a stroke. The goal should be to reduce the systolic blood pressure by 10 to 20% in the pre-hospital setting. The systolic blood pressure should be maintained around 160 to 180 millimeters per mercury. For hypotension that's non-traumatic, this protocol is for non-pregnant patients with hypotension not thought to be associated with trauma. The patient may have an altered mental status if the blood pressure is low enough. Usually a systolic blood pressure less than 90 millimeters per mercury will cause changes in mental status due to poor brain perfusion. For pediatric patients, refer to the Pediatric Blood Pressures by Age Appendix on page 172. Yeah, we'll get there eventually. For the minimum systolic blood pressures in children. For the history, watch out for fluid loss, such as vomiting or diarrhea, blood loss, such as a GI bleed or gastrointestinal bleed, and vaginal bleeding, an allergic reaction with a history of insect bites, new foods or medications, chest pain, cardiac ischemia, which is a lack of oxygen, poisoning or overdose, pulmonary embolus risk factors, pregnancy, poor oral intake, dehydration, infection, and syncope, which is fainting, or drug use. For the symptoms, we're looking for an altered mental status, lightheadedness, chest pain, palpitations, melena, shortness of breath, weakness, and dizziness. Some differential diagnosis that we can look for is hypovolemia via dehydration, vomiting, diarrhea, GI bleed, ruptured ectopic pregnancy. We could watch out for septic shock, anaphylactic shock, cardiogenic shock, which could be an acute MI or myocardial infarction, medication-induced overdose, or a pulmonary embolus. For BLS, or basic life support, there's ABC, or airway breathing circulation. You can apply oxygen via a non-rebreather mask, can obtain their history to identify possible causes of hypotension, place the patient in a shock position with their legs elevated if the patient tolerates it, be cautious if the patient has shortness of breath, obtain vital signs including a temperature to watch out for possible sepsis, check their blood glucose levels, watch out for pulse oximetry. You may have difficulty reading it due to the hypotension and poor tissue perfusion, so just be ready for that. For ALS, or advanced life support, intubate the patient as necessary. Establish an IV access with a large bore IV. Administer IV fluids at 250 to 1,000 cc's or 20 mLs per kilogram for a child of an IV bolus. Titrate to keep the systolic blood pressure greater than 100 millimeters per mercury in an adult. Follow the vital signs and lung sounds closely. If the patient develops rhonchi, crackles, or wheezing, consider the administration of norepinephrine drip 8 to 12 micrograms per minute IV. Monitor their EKG rhythm. Obtain a 12 lead if the time allows you to. Establish a second large bore IV if available, or if possible. If patient's blood pressure shows no improvement and they're still hypotensive after 2,000 milliliters of normal saline, consider the administration of 8 to 12 micrograms per minute of norepinephrine via a drip. Titrate the norepinephrine to keep their systolic blood pressure greater than 100 millimeters per mercury. Use caution when infusing large volumes of IV fluid to CHF or congestive heart failure patients or patients on dialysis. Contact medical control for any guidance needed on using norepinephrine, as it may be used earlier depending on physician preference. Avoid norepinephrine in patients who are significantly volume depleted. The treatment of hypovolemia is IV fluids, not norepinephrine. Due to the typically short transport times in Corpus Christi, it would be very rare for norepinephrine to be administered. So just be prepared to potentially never administer this as far as your paramedic career goes, at least with Annaville. Remember that small patients, especially young females, often have a baseline systolic blood pressure of 90 millimeters per mercury. This protocol is intended for symptomatic patients only. Consider all possible causes of shock and treat using the appropriate protocol. Newborn resuscitation. Most term newborns require no resuscitation beyond positioning of the airway with supine with the neck slightly extended, warming, suctioning, and stimulation. See Childbirth Protocol, page 53. This protocol deals with the resuscitation of newborns that has not responded to normal post-delivery measures. For some history, If it's an infant with a field delivery, the mother may have excessive bleeding. There may be premature rupture of the membranes, maternal fever, maternal hypertension, and maternal seizures. So watch out for all of these. For symptoms, it's an infant with a low APGAR score, and you should know this if you're going to take the national. For the physical examination, it's poor or absent respiratory effects or efforts, central cyanosis, decreased muscle tone, abnormal newborn heart rate, less than 120 to greater than 160 beats per minute, with abnormal respiratory rate of less than 40 to greater than 60 breaths per minute. For BLS or basic life support, we want to maintain their airway. We want to suction the mouth, then the nose with bulb syringes. We want to thoroughly dry and stimulate and keep the babies warm. Wrap them in a towel or a blanket. It is extremely important to keep the newborn baby warm. Spontaneous respiration should begin 15 seconds after tactile stimulation, flicking or rubbing of the soles of the feet or the buttocks. If shallow, slow, or absent respirations occur, begin BVMing or bag valve masking the patient immediately. Assess their heart rate, palpate an umbilical cord, a brachial or femoral artery, or auscultation of the apical heart sounds, and skin color. If the patient is breathing with less than 100 beats per minute with a heart rate, and the skin shows evidence of central cyanosis, hold 100% blow-by oxygen close to the patient's airway. If the heart rate remains less than 100 beats per minute after oxygen and labored respirations persist with central cyanosis, use a bag valve mask with 100% oxygen. Do not delay oxygen treatment. If the heart rate remains less than 60 beats per minute or is absent after 30 seconds of adequate assisted ventilations, this is very sad, with a BVM and 100% oxygenation, then begin chest compressions with a depth of half an inch or 1/3 the anterior posterior depth of the chest and a rate of 120 beats per minute. You want to try to coordinate with your partner with chest compressions with the ventilation ratio of a 3-to-1 ratio, but it's only if you have your partner. If for whatever reason you're doing it by yourself, just do the regular 30-to-2. 90 chest compressions and 30 ventilations per minute is ideal though with the 3-to-1 ratio. You'll have a partner, so this shouldn't be an issue. Determine APGAR score at 1 minute and 5 minutes if allowed. Do not delay resuscitation in order to obtain an accurate APGAR score. So just keep going with your CPR call. Check their blood glucose. Always consider hypoglycemia in a newborn resuscitation, especially if there's a history of maternal diabetes mellitus. For ALS, well, this is tough. Intubate an infant as needed. Secure the endotracheal tube carefully as neonates can easily be extubated due to their short trachea. All heavily stained meconium deliveries should be intubated and suctioning should be applied directly to the endotracheal tube, or alternatively, a small suction catheter can be inserted down the endotracheal tube. Only suction for 5 seconds at a time to avoid removing too much oxygen from the lungs. Once the infant is thoroughly suctioned, and if the infant is breathing well, the endotracheal tube may be removed. Monitor an EKG rhythm. Refer to specific dysrhythmia protocol as needed. Establish IV access. You may need to place a proximal tibia intraosseous line, an IO, if unable to easily place peripheral IV access on 2 attempts or after 90 seconds, or if the child is in cardiac arrest. Administer IV fluids at 10 milliliters per kilogram. If signs of hypoperfusion exist, if the blood sugar is less than 70, administer D10 at 2 milliliters per kilogram or 0.5 grams per kilograms for pediatrics via IV. If the heart rate remains less than 80 beats per minute, administer 1 to 10,000 at 0.01 milligrams per kilogram IV or IO initially. If needed, subsequent doses of epinephrine 1 to 10K at 0.01 milligram per kilogram IV or IO can be administered. Consider naloxone or Narcan at 0.5 milligrams IV or IM or IO if the possibility of maternal opioid ingestion exists. Note, keep all newborn infants warm to preserve body temperature, decrease oxygen demand, and prevent acidosis. Atropine does not work in neonatal resuscitation, undeveloped parasympathetic nervous systems. Furthermore, it can cause paradoxical, or the exact opposite where it'll get worse, bradycardia, and asystole if administered to children less than 3 months old. Very few infants will require epinephrine. Most will respond to oxygenation and ventilation. The 2-thumb encircling hand technique of chest compression is preferred for chest compressions in infants performed by healthcare workers when 2 rescuers are available. This replaces the old 2-finger compression technique for 2 rescuer infant CPR by healthcare providers. Data shows that the 2-thumb encircling technique can provide better blood flow with higher peak systolic and coronary perfusion pressures. The 2 thumbs are placed on the middle 1/3 of the sternum, and the fingers are encircling the chest and supporting the back. It is recognized that these situations in which gestational age of the newborn cannot be easily ascertained in regards to the viability of the newborn. As a guideline, if the neonate has both ears and eyes developed, it is likely that they're at least 24 weeks or above and should have attempts of resuscitation. Newborns without ears are less likely to have 22 to 24 weeks of gestation and will not be viable to be resuscitated. These cases can be difficult for the medic on scene and should always involve medical control for guidance as needed. Next up, we have OB emergencies. So most pregnancies progress in a normally orderly fashion. Any abnormality in pregnancies will affect both the mother and the child. Always remember you're treating 2 patients, so transport them to the hospital as a priority unless delivery is imminent. Field delivery will usually be unavoidable if the mother cannot stop herself from pushing or if the head is visible at the vaginal opening. If the birth has a high risk or anticipated complication, it may be best to begin transport to the hospital. If a pregnant trauma patient is greater than 20 weeks gestation, they require spinal motion restriction, securely package the patient's supine, and tilt the spine board on its left side at 45 degrees at an angle with a blanket or padding. For history, you want to check the due date. Is a baby full term? When was the last known normal menstrual period? Is this a multiple birth? If it is, you want to call for a second ambulance. You want to know the time interval between contractions and duration of contractions, the number of times that the patient's been pregnant, which is gravity versus parity, which is the number of prior births. You want to check the history of complications with or prior pregnancies. See if they have gestational diabetes, hypertension, edema, or visual changes. Any vaginal bleeding. Has the bag of water, the amniotic sac, ruptured? And what time and what color was it? Is there fetal movement present? Have they been using prenatal care? And prior non-emergent maternal medical history. For symptoms, we're looking for contractions, vaginal bleeding, and rupture of the membranes. And for BLS for childbirth, we want to watch out for ABCs, apply oxygen, a nasal cannula if the patient is stable, a non-rebreather if there's evidence of maternal or fetal distress, obtain vital signs. You want to watch out for the maternal SpO2. You want to do a perineal exam. You want to look for crowning the top of the baby's head if it's visible between contractions, which signifies imminent delivery. If the patient is not crowning and it is not the head, refer to the breech delivery or limb presentation section below, which is not good. Anticipate immediate delivery if the contractions are less than 2 minutes apart or crowning is present. If imminent delivery is not anticipated, place the patient in the left lateral recumbent position on the patient's left side and begin transporting the patient to the hospital. The left lateral recumbent position avoids compression of the inferior vena cava by the gravid uterus that decreases venous return to the heart. For delivery, place the mother supine at the edge of the bed or the stretcher with her feet on a flat surface and her knees bent. Place a clean sheet or towel under the buttocks area. Remove the patient's underwear and any constrictive clothing. Open the OB kit while maintaining a sterile field as possible. Put on sterile gloves, mask, and a gown if available. Have the mother pant, breathe during contractions, and relax in between. Recheck for crowning. Once crowning is seen, apply gentle pressure to the baby's head. Remember, they have a soft fontanelle to prevent an explosive delivery with resultant tearing of the vaginal tissue. Allow the head to deliver gently. Usually the face will be facing down posteriorly. Immediately use the bulb syringe to suction the baby's mouth before it takes its first breath. Then nose as soon as the head delivers. So immediately use the bulb syringe to suction the baby's mouth before it takes its first breath. Then the nose as soon as the head delivers. Suctioning the nose should stimulate breathing. If meconium is present, refer to the section on meconium that is found on the next page. Check for the umbilical cord around the neck, a nuchal cord. If found, gently slip it over the infant's head. If it's wrapped up too tightly and not a multiple birth, clamp it in 2 places and cut between the clamps. Use caution in clamping a cord when multiple gestations are expected. After the head delivers, there is normal rotation of approximately 45 degrees. Next, Deliver the shoulders one at a time gently. Guide the head down for the upper shoulder to deliver, then upward for the lower shoulder to deliver. Suction the infant again. If the baby does not begin breathing spontaneously after delivery of the baby, stimulate it, slap the feet. If normal respirations do not begin within 15 seconds, refer to the newborn resuscitation protocol on page 51. Dry the infant thoroughly. This is extremely important. Assess the infant for respiratory effort and heart rate. Determine the APGAR score at 1 minute and 5 minutes. So you can see here's a detailed list of the APGAR scoring going from appearance, the pulse or the heart rate, the grimace, which is the reflex irritability, the activity or muscle tone, and the respirations. You can look this up on your own time, but it's a score of 0 to 2, 10 being the best score, 0 being the worst. Maintain the baby's warmth, cover the body. After the delivery is complete, the baby should be kept at the mother's birth canal level with the head down slightly to allow for further drainage of airway secretions. Cut the umbilical cord by first applying clamps or hemostats or umbilical tape 6 inches from the baby's navel, with the second clamp 1 inch distal or away from the first. Cut between the clamps with a sterile instrument, scissors or a scalpel blade. For the third stage of pregnancy, the delivery of the placenta. During this phase, the placenta, the remaining umbilical cord, the amniotic sac, and the lining membranes should all be delivered. Delivery of the placenta should take place naturally, but do not wait for the delivery of the placenta to begin transport to the hospital. It may take 20 to 30 minutes. Never tug on the umbilical cord to aid in placental delivery. Rather allow the placenta to deliver on its own. Gently massaging the lower abdomen will minimize bleeding and facilitate delivery of the placenta. That's known as a fundal massage. For post-delivery care, the placenta delivery will always be followed by some vaginal hemorrhage. Place a dressing over the vaginal opening. Rather vigorous massaging of the lower abdomen over the uterus, a fundal massage, just like I talked about, will help in the contraction of the uterus and usually slow the vaginal bleeding. If delivered in the field, bring the placenta to the hospital for verification that the entire placenta was delivered. For ALS, place the mother on the cardiac monitor and establish IV access on the mother. Only administer fluids if the blood pressure is less than 100 millimeters per mercury or if they have significant hemorrhage. Note: attempt to transport the patient to their hospital of choice. However, if any complications occur, such as a hemorrhage or neonatal distress, divert to the closest appropriate hospital that has labor and delivery services. It is also best to attempt to transport to the hospital for delivery at the hospital, especially if short transport times, if premature delivery, breech or limb presentation, a prolapse cord, or an unstable vital signs are presenting. A pregnant patient in cardiac arrest should be managed according to the ACLS guidelines with rapid transport to the closest appropriate facility. Give the hospital early notification of your transport so that a neonatal team can be mobilized for a possible emergent C-section. Now, these are delivery complications. If there's a breech presentation with the buttocks first, deliver the buttocks and support the baby as the head is delivered. If necessary, insert 2 fingers in a V shape on either side of the baby's nose to provide an airway while completing the delivery. The baby's head should deliver within 2 minutes. Gentle pressure over the lower abdomen uterus may be of help. For a limb presentation, a foot or an arm, place the mother in a left lateral recumbent position and keep exposed parts moist with normal saline dressings. Do not pull on any part of the body. Limb presentations with the transverse lies are not deliverable in the field. Transport immediately with the mother on high flow O2 via non-rebreather mask. Prolapse umbilical cords. The umbilical cord is delivered before the baby. Do not push the cord back in. Administer high flow O2 and begin rapid transport. Using a gloved hand in the vagina to continuously push the baby's head away from the cervix and keep the pressure off the cord. This may be helped with the mother in the knee to chest position with hips elevated as high as possible. Keep an exposed cord moist with normal saline. Meconium. If they're heavily stained with a brownish yellow fetal stool, staining is noted with the delivery through suctioning of the nose or the mouth and then the nose as indicated. This should be performed immediately after the head is accessible and before the thorax is delivered. Immediately performing endotracheal intubation in the standard procedure and apply suction directly to the endotracheal tube and suction out the lungs if we're concerned about meconium. Repeat as needed until the tube is cleared of secretions. Excessive bleeding. If excessive bleeding is encountered after the placenta has been delivered, proceed with a vigorous massage of the uterine fundus using a circular motion. If effective, the uterus should be left to harden, or should be feeling as though it's hardening under your massaging hand. Place pads externally over the vaginal opening and hold gauze bandages over any visible vaginal or labial laceration seen. Make sure the patient is on high flow too and administer IVF normal saline boluses. Prematurity. A preterm delivery is a neonate less than 36 weeks of gestation and usually less than 2,500 grams. Deliver a premature infant as with a normal infant. They may require more conscientious drying and warming procedures as they are much more prone to hypothermia. A non-porous device can be used to aid in warming, such as aluminum wrap, such as a silver swaddler. They are more prone to hypoglycemia, thus a blood glucose assessment should be done if indicated. Multiple births. Suspect if strong contractions continue after the first delivery and the baby is smaller than expected. Labor for the second delivery begins usually after 10 minutes after the first delivery is completed. Fraternal twins each have their own placenta, while identical twins share the same placenta. Attempt transport if the time permits, but be prepared to deliver en route to the hospital. For preeclampsia or eclampsia, which is also known as toxemia. For the introduction, pregnant patients with an intrauterine pregnancy greater than 20 weeks with the new onset of maternal hypertension, a systolic blood pressure greater than 140 millimeters per mercury, and a diastolic greater than 90 millimeters per mercury. Remember, the pregnant patient usually has a lower blood pressure than a non-pregnant patient. Preeclampsia is a condition of hypertension, swelling, and visual disturbances, while eclampsia refers to a preeclamptic patient who has had a seizure or has altered mental status. Preeclampsia patients usually occur in the third trimester of the mother's first pregnancy and may occur up to 4 weeks postpartum. Some history: they may have a history of preeclampsia, edema, visual changes, usually normotensive prior to the pregnancy. Some symptoms include a headache, swelling, visual changes, abdominal pain, nausea or vomiting, and tremors. Some physical examinations may be they have swelling, hypertension, seizures, an altered mental status, tremors, and increased reflexes. For BLS or basic life support, we want to monitor their ABCs. We want to apply oxygen if necessary and use an MPA or BVM as needed. Obtain vital signs. Check your blood glucose levels. If it's less than 70, then refer to the Diabetic Emergencies found in page 37. Reassure the patient and keep her as quiet as possible. Place the patient in the left lateral decubitus position, the right side up, and protect the patient from injury if they're actively seizing. You also want to place them on a pulse oximeter. For ALS or advanced life support, intubate the patient if needed. Establish an IV access of normal saline at 60 milliliters per hour or saline lock. Monitor the EKG rhythm. Go ahead and get a 12 lead on them. Administer Zofran 4 milligrams or 2 milligrams for a child, IV or IM, for active vomiting. Administer mag sulfate at 2 grams IV over 2 minutes if the patient has had a seizure but is not actively seizing. Administer mag sulfate 2 grams IV over 2 minutes if the patient has an extremely elevated blood pressure, either a systolic greater than 160 units or a diastolic at 110 or greater, and any significant signs and symptoms of preeclampsia, including swelling, headaches, and visual changes, even if they have not seized yet. If the patient is actively seizing, administer a total of mag sulfate of 4 grams IV over 2 minutes. Monitor the patient's respiratory status closely. If the patient is still seizing after 4 grams of IV mag sulfate, then administer diazepam Valium 5 milligrams to 10 milligrams slow IV push. Administer diazepam until the seizure stops or a total of 20 milligrams of diazepam has been administered. Use diazepam conservatively, as it will result in a fetal intoxication. If IV or IO access cannot be obtained, administer Versed or midazolam 2 milligrams to 5 milligrams IM or via a MAD device may be administered for seizure treatment. Contact medical control for a guidance if the patient is still seizing after 4 grams of mag sulfate and 20 milligrams of diazepam or 5 milligrams of IM midazolam has been administered. The patient must be on the pulse oximeter and cardiac monitoring if diazepam or midazolam has been administered. Proceed with a rapid transport to an appropriate OB receiving hospital for likely emergency C-section. Note: for a hypertension, it always results in decreased perfusion of the placenta. A blood pressure greater than 140 over 90 millimeters per mercury is always significant in a third trimester patient, regardless of the extent of maternal symptoms. Seizures are due to chemical changes which occur with preeclampsia. These chemicals lower the maternal seizure threshold, and seizures can occur from hypoxia in the fetus. Mag sulfate is a potential or a potent vasodilator which decreases the blood pressure and increases the seizure threshold, reducing the seizure risk. The definitive treatment of eclampsia is delivery of the baby. Now we're going to look at third trimester bleeding. So to introduce this, it's a patient that's greater than 28 weeks pregnant. You never want to attempt a vaginal bimanual exam in the field, as severe bleeding may result just by disrupting the clots. Two main causes of third trimester bleeding are usually abruptio placenta, which is a premature separation of the implanted placenta from the uterine wall, associated with toxemia, diabetes, drug use such as cocaine, trauma, or idiopathic reasons such as unknown reasons, can cause painful bright red bleeding. Or it can be placenta previa, which occurs when the placenta is located either close or to overlying the cervical opening to the vaginal region, causing painless bright red bleeding. Some history is the amount of bleeding that is what you want to gather, the number of pads that the patient used, the time when the bleeding began, are any clots or tissues that may have passed, syncope, which is just fainting, and estimated date of confinement, the due date. You want to check for symptoms such as dizziness, weakness, increased thirst, shortness of breath, and syncope. For BLS, you want to maintain your ABCs. You want to apply oxygen or high flow O2 via a non-rebreather. You want to obtain vital signs. There are often significant hypotension that's present. And you want to place them in the left lateral recumbent position and in a shock position. For ALS support, you want to monitor an EKG, go ahead and get a 12 lead, establish IV access. A large bore on the AC is usually preferred. Administer IV via fluid saline and titrate as needed to maintain a blood pressure greater than 100 millimeters per mercury. Monitor their vital signs closely. Start a second line if possible if they're hypotensive. And you want to have rapid transport to the hospital. Notify the receiving hospital early so that packed red blood cells can be acquired from the blood bank as needed. In addition, labor and delivery can be notified, and an obstruction can be present on arrival in the ED as needed. For psychiatric behavioral emergencies, you always want to protect yourself when dealing with a potentially combative patient. Have PD respond to the scene as needed. Consider other causes for bizarre behavior besides psychiatric disorders such as stroke, seizures, infections such as meningitis, hypoglycemia, hypoxia, head trauma, or drug and alcohol ingestion. Refer to the altered mental status protocol as needed on page 25. So, for some history that you want to gather, you want to see if they have any alcohol or drug use, auditory or visual hallucinations, paranoia or homicidal ideations. That's a really big one. History of psychiatric disorders, or if they're on any psychiatric medications, behavioral changes, depression, situational crisis. And for symptoms, you want to watch out for any bizarre thought content, hallucinations, chest pain, anxiety, shortness of breath, potentially like a wrist laceration, etc., agitation, confusion, expression of suicidal and homicidal thoughts or actions. So, you want to, for the BLS side, confirm scene safety and ensure that you have a protective environment for yourself and the patient. Contact a PD early if you're considering that this is a possible dangerous situation, and make sure that dangerous objects like knives, guns, and pills are removed before you get on scene. Establish a rapport with your patient and constantly reassure the patient. Use verbal calming techniques to calm them, and communication is very important. Do not leave the patient alone unless needed for personal safety. Remove the patient from any stressful environment. If the patient allows it, obtain vital signs. And if restraints are required to protect the patient and EMS provider to control aggressive behavior, only use authorized restraints. And I hate this idea, but if you need to, you need to. You can use commercial soft leather or other soft materials such as Curlex, sheets, triangular crevettes, etc. And they're to be used See page 169, the patient restraint appendix. If the patient is handcuffed by law enforcement, it is expected they will either accompany you or they will follow the ambulance to the hospital. Never restrain a patient prone, face down on the stretcher. We've talked about this before. You can use a mask or a face shield on a patient and yourself too, is always a good idea. If they're threatening to spit, apply oxygen if they're lethargic or have unstable vital signs. Check their blood glucose levels. Administer oral glucose 15 to 30 grams by mouth if they're able to protect their own airway. If they have an intact gag reflex and their ANO times 4. And make sure you get an SpO2. For ALS, monitor a 12 lead. Establish IV access if the patient allows using a normal saline 60 ml per hour lock, or known as a saline lock. Administer naloxone or Narcan 2 milligrams via IV, intramuscularly, or mucosal atomizer device, and or a D10 via IV if needed. You can also administer glucagon 1 milligram or 0.5 milligrams intramuscularly if the patient is hypoglycemic and IV access cannot be obtained. You can administer midazolam or Versed 1 to 5 milligrams with a slow IV push, or 2 to 5 milligrams intramuscularly or with a MAD device if needed to control an extremely agitated patient. The patient must be on oxygen, and a pulse oximeter is necessary if midazolam is administered, but you'll have them on this anyway. Some notes: always be suspicious of other etiologies in patients suspected of behavioral disorders and with alcohol in their breath, especially head trauma or hypoxia. Never forget to measure a blood glucose level in a combatant patient. They may be hypoglycemic, especially alcoholic patients. Patients are not permitted to sign a refusal of care, no transport. Use law enforcement and contact medical control as needed for guidance. Paramedic personnel may utilize the mucosal atomizer device as an alternative to drug delivery adjuncts for patients without IV or IO access who require the urgent administration of Narcan or midazolam Versed. See protocol on page 152.